Thank you, Heather. So welcome everyone. We're just a couple more people will be filing in, but thank you so much for joining us for NCAAR's Let's Talk About It webinar series on the wounded state of wound care in New Jersey. My name is Summer Brancaccio and I'm the president and CEO of NCAAR. So for over 40 years, NCAAR has been working to advocate to advance the public health approach to substance use through grassroots advocacy, training and education, such as this webinar, and progressive policy initiatives. And every level of our advocacy really works to center the stories and the voices of those with lived experience so they can inform the system of care that serves them. So we are really honored to partner with our expert panelists today, both of whom have been longtime dedicated advocates on both the state and national level. So Dr. Alexis LaPietra and Mike Santillo. Dr. LaPietra is a board certified physician in addiction medicine, and she is the system director of addiction medicine for the emergency medicine hospitalist service line at RWJBarnabas. She completed her emergency medicine residency at St. Joe's in 2014 and went on to complete a pain management fellowship. She founded the St. Joe's Alternatives to Opioids program in 2016, which became not only a national model for pain management, but also led to the passage of national legislation, which was the Emergency Department Alternative to Opioids Act, which was part of the larger Support for Patients and Communities bill, which garnered strong bipartisan support and was passed in 2018. And Dr. LaPietra's work has been highlighted in the New York Times, CNN, Fox News, NPR, MSNBC, so she's everywhere. And her focus really remains on reducing stigma and barriers to providing comprehensive addiction care within all healthcare settings, integrating harm reduction for substance use into medical practice, and really enabling health engagement throughout every phase of use and recovery. So we are so happy to welcome her today. And then we also have Mike Santillo, who probably needs no introduction. He is a licensed clinical alcohol and drug counselor for 35 years of experience in the behavioral health field. Right now, he's the chief operating officer at Prevention Links, which is a statewide prevention and recovery support service provider in New Jersey. And prior to his work there, a lot of us know him as the former chief executive officer at John Brooks Recovery Center. And throughout his career, he has designed, implemented, and supervised such a wide array of services across the whole continuum, including residential and outpatient programs for both substance use and mental health, MAT fixed and mobile programs, supportive housing, recovery housing, reentry programs, ORP, and recovery community centers. He's also worked as a consultant to the New Jersey Administrative Courts and Public Defender's Office. And he has served on multiple state and national advisory boards, too many to mention, but that includes SAMHSA's State's Best Practices Opioid Misuse Prevention and Treatment Panel, and the Recovery Research and Evaluation Technical Expert Panel. And Mike is a recipient of the NJAMA Visionary Leadership for Substance Use Recovery Award and NJCAAR's Outstanding Community Leadership and Service Award. So we are very happy to have him as well. So we're really grateful they're here to share their impressive and well-accomplished expertise today, particularly on the need for improved integration between our physical healthcare system and our behavioral healthcare system to better support recovery. Tanya Ahern was listed on the flyer. She could not be here to moderate today, but our discussion will be led by longtime advocate and NCAAR's field trainer extraordinaire, Heather Ogden, whose years of work in this space have made her a sought after trainer, consultant, and expert as well. So thank you everyone for being here, and I'm going to pass it over to Heather.
Thank you very much, Summer. And thank you to our panelists. Thank you, audience, for joining us today. Thank you to our friend Michelle, who is doing our tech support today. Before we jump in, a little bit of housekeeping. We do have our Q&A open that will be monitored by Michelle, Summer, and myself. Please use the Q&A, not the chat, for your questions. It's tough to jump back and forth. We might miss it if you drop it in the chat, so try and put it in the Q&A. And you can drop them at any point, and we will make sure we get them to the panelists. As Summer mentioned, we were hoping that Tanya would be able to host today. She is here online, but she is not cleared to come back to work yet, but she is doing much better. Those of you that are aware that She had some health issues. She's feeling much better. We're glad she's here attending, and we can't wait to have her back. She put a lot of work into putting this webinar together. All I'm doing today is just stepping in to make sure that we're online. That's it. So she did the hard part. I'm just here to I have the honor of being able to chat with you guys today. So as Summer said, I am the training coordinator with NCAAR. Tanya is our advocacy coordinator. One of my other positions is I actually do work in the harm reduction division at the Department of Health now. So obviously, harm reduction is something that on the recovery spectrum we have been interested in many years, but it is just starting to gain traction. And those of us who work in the extended field, where we know recovery is a gigantic spectrum, and it's multiple pathways, and it's individually tailored and needs to be based on the individual. Those of us that are working in it on all levels, frontline, clinical, medical, we know that there are so many different issues that our folks are dealing with. And with all of the different pollutants that are in our drug supply now, especially xylazine, we are seeing a whole lot of new medical issues popping up that have become such a large hurdle for our folks. And so we're here to talk about that a fair amount today. So with that, let's go to the experts themselves. And I'm going to turn it over to Dr. LaPietra to talk a little bit about what she has been seeing and what the medical profession has been seeing, especially with xylazine entering the supply, with the wounds that our folks are now struggling with. Dr. LaPietra, can you give us some more background on what you have been seeing and what are the hurdles and what should we know as providers?
Thank you guys for having me. It's a pleasure to be here. The issue with xylazine really is, it's hard for all of us, anybody who's dealing with this client or patient base. The road to recovery looks different for everyone. And you know, there's a lot of pain and suffering, of course, in the use disorder population. Medical issues always arise in all human beings. In the use disorder population, we see some unique issues, but adding now on top of it the wounds. What I'm hearing from the front line in terms of the outpatient setting for treatment is this is another barrier because of the unfamiliarity with wounds, because traditionally wounds in people who inject drugs mean bacteria or antibiotics or endocarditis, because traditionally we have been associating wounds with something very bad. The xylazine wounds, which tend not to be bacterial, they are causing that barrier of we can't admit you. This is what I'm hearing. I mean, of course, I'm in the hospital setting. I'm not in that treatment area, but we're getting a lot of referrals to the ER or to the hospital saying we really need clearance. Typically, you know, is this contagious? We can't have open wounds, and that is understandable. The issue, and we all know this issue, and Mike will talk about it. He knows much more than I do about the siloing with licensing. It contributes to mortality and morbidity. So when folks are ready to seek care, and we have that, you know, window of opportunity, and they present with a wound, the multiple steps they must go through to then come back to where they are now is a failure. It's a gross failure. We would never imagine someone following up with cardiology and then saying, oh, but you know, you've got to go here, there, and the other place, and I know you don't have a car. We'll try to book your appointment for 4 weeks out. We don't see those I mean, there are barriers to healthcare, but we know the unique challenges of transportation and, you know, again, that short window for use disorder patients that it becomes oppressive. So what can we do? I think we all, medical professionals, treatment providers, we went into this when I joke when we wrote our medical school applications, or we wrote our applications for our masters or degrees, we went in this to help people. That no one's in this, hopefully, if they're not looking to help. We get really bogged down with charting our own, work and the heaviness that is modern medicine in 2024. But when there are public health crises, we have the obligation to familiarize ourselves with the current state and to evolve. As we get older, that becomes less easy. We have more and more experience doing things one way. We have a lot of feedback about how that one way works. And we maybe have some bad outcomes, so we decide we're going to do it this certain way. But when COVID came around, this was something no one knew about. So it was quite an interesting experiment. I had been talking about buprenorphine harm reduction before COVID. And the issue was, it's hard for folks to change. We've been doing it this one way for a long time. It's the culture. And I get that, understand. But when we were presented with a global pandemic, a very novel, horrifying disease with high mortality, sounds similar. We rallied. Thank God. We rallied, and now we're past it. It was grossly traumatizing, like it can be dealing with use disorder patients. It's heavy at times. But if we can rally and be so flexible when there's a public health crisis like COVID on our doorstep, well, you showed us that there really is no issue with us being flexible and us stepping up. What it has to do with is really, I think there's top-down pressure, of course. The CEOs and the directors, executive directors of organizations, everyone had to prioritize COVID operations. They had no choice. We also don't have a choice with operationalizing more harm reduction focused strategies, but it does have to come top down. Our boots on the ground staff cannot start evaluating wounds, treating wounds, admitting patient with wounds if they don't have support and infrastructure. So I challenge, leadership to band together in a way to, and this is what we're here to do, advocate to the state, advocate in the communities, decide I'm going to make a friend at the Harm Reduction Center. I'm going to figure out where I can refer. Even the hospitals talking to the treatment centers. Is there a telehealth option? I have Alexis here. She's looking to get into treatment. I don't want to have to give her the runaround, but she has some wounds. Are you able to help me with this? Could we maybe hop on screen and discuss this a little bit? So I feel like we have shown the world with COVID that we can be flexible in all spaces because every aspect of our world was affected by COVID. And so I believe even a part of that needs to be placed on prioritizing harm reduction because of the significant morbidity and mortality. We are continuing to fail these patients because we are dogmatic and paternalistic in our healthcare. And again, for physicians, it's the same thing. This is something new. I get it. You weren't trained on that, but read your med school application. It said you wanted to help people and you were a forever learner. We're forever learners. So we have to just kind of continue to destigmatize, humanize, and help all of our colleagues, medicine included, to really appreciate the significant role they play and how barriers lead to death. I'm going to pause there.
Sure that just like myself, who people can see nodding along, and Mike's nodding along, and Summer's nodding along, I'm sure our participants are as well. So that's a wonderful intro from the medical perspective. So we've got that, physical aspect of it. So I'm going to turn it over to Mike now. Mike, you have both frontline outreach worker and clinical experience with everything that we're talking about today. I'm sure that you also identified with a lot of the aspects that the doctor was speaking of from a clinician's perspective. So do you want to talk to us about some of the barriers that you see in your various positions as an advocate and a professional in this realm?
Yeah, absolutely. And I agree with everything the doctor said. So, we're kind of focused on wound care here, but I need to put that question about barriers into a larger context, which is really the context of integrated care. And what are the barriers for integrated care? What do I mean by integrated care? Basically, I'm going to keep it simple. Basically, we're talking about whole person care, right? We need to treat the whole person. None of us are our diagnosis. None of us is just a substance use diagnosis, a mental health diagnosis, a physical health diagnosis. We're whole people, and we need to treat people in that manner. So that's what we're talking about when we say integrated care. For years, I've been, probably the last 20 years of my career, I've really been focused on advocating for and trying to actually operationalize integrated care. What I mean by that is integrating primary care, behavioral health, which is both substance use and mental health, and also recovery support services, which are incredibly important. We have a lot of data to support that. Some people say, well, where does harm reduction fit into that? I think harm reduction fits into all of that, different aspects of harm reduction. I look at harm reduction as a integrated care model. If you're really doing the way, harm reduction the way it's meant to be done, it really is this kind of integrated model. Good friend of mine, Brad Goodfine, out of Washington State. He's a national leader in the advocacy for harm reduction. He always says harm reduction is health engagement, right? And that's really what we should all be focusing on, right? No matter what the access point, no matter how people get into the system, the goal should be to integrate, to engage people in healthcare, full whole person healthcare, right? Not just one little segment of the healthcare, because we know there's a lot of morbidity. We talk about co-occurring conditions. So integrated care. Just the fact that we're talking about the need for integrated care means that we have a fragmented healthcare system, right? We talk about silos. We have all these different silos. Over here is mental health. Over here is substance use. Over here is primary care. We have all these silos. It's a fragmented system. I believe that system is fragmented because of stigma and discrimination against people with substance use disorders and mental health illnesses. I think in general, over the years, over many, many years, long before I got into this field, our healthcare systems really didn't want to deal with that population for multiple reasons, most of which was stigma and discrimination. So we have this very fragmented healthcare system, and I've been a treatment provider I retired from treatment in June 2nd of last year, but I was a treatment provider for 35 years and worked in nonprofit organizations that were all rooted in grassroots, right? They were all these organizations that had grown over the years, like John Brooks Recovery Center, which when I left was, had a $21 million operating budget, but it started in the front of a little storefront in downtown Atlantic City, right? I worked at Eva's Village. It started in the basement of a church. Turning Point, it started in an abandoned building on the Essex County psych complex, right? There was this gap left by healthcare that grassroots organizations had to get in there and try to fill that gap. Those organizations now have grown into large organizations, but are still tiny compared to the overall healthcare system, right? So that's where our system is. And of course, we've seen improvements over maybe the last 10 or so years, largely driven by the opioid epidemic, but we're still far away from that, even the realization of integrated care, right? So what does that mean? It means that all of the rules, all of the regulations, all of the funding mechanisms, all of the way we license and credential people, and even educate and train people is all driven by this fragmented healthcare system that's been around for decades and decades. and it is deeply, deeply embedded in everything that we do. All right, sounds terrible, right? Is there any way out? But just to kind of give you an example, the Department of Health right now is working on what's called an integrated care license. The idea is to create one single license that a provider can obtain to provide primary care, mental health, and substance use disorders in one site. Right now, if you want to do that, you have to get 3 separate licenses. And there are actually regulations that prevent, and I love this word, commingling. You can't commingle the populations, right? As if, again, it's that idea that it's separate, right? I mean, you got your mental health over here and your physical health over, right? We can't commingle. I don't know, when last time I went to the emergency room, there was no problem commingling. And the last time I went to my primary care physician, there was no problem commingling. People are in those places for a lot of different reasons, right? So there's these regulations that right now you have to have, and so, you know, when I submitted to get a mental health license, it took 2 years to get a mental health license. One of the first things I did when I got to John Brooks Recovery Center is we applied for a primary care license. It took 1.5 years. We had been providing, because part of running an OTP is providing basic physical health services, like we do annual physicals, we do physical exams at admissions. We have nursing staff, we have a medical director, we have a director of nursing. But it took me another 1.5 years to get a physical primary care license, right? So the Department of Health is developing this integrated care license. Well, it's been about 7 years. They're still working on it. So, right, this came from a kind of a mandate from Governor Christie back in his administration that we really have to integrate primary care, mental health, and substance use. And so we're going to develop this license. They've been working on it for about 7 years. Now, okay, we did have this thing called COVID pandemic. And yes, the Department of Health was pretty busy for 3 years. I get it. I get it. I get it. But still, even if you take 3 years, it's still, we're looking at like 4 years. And yes, the new commissioner of the Department of Health, Caitlin Baston, you know, spoke Tuesday, I think it was, at the Department of Human Services and Division of Mental Health and Addiction Services Opioid Summit. And she said that this was a priority for her and her department. And I know Caitlin, and I admire her, and I respect her, and she's done fantastic work around substance use disorder and around integration at Cooper Hospital. But even, you know, she said that they're not even ready to post those regulations yet for comment. And if you know the process, you know that regulations have to be posted for comment, that you have to wait a couple of months for that, and then there's a process after that and a process after that. So we're probably still, I mean, you know, 1 year, maybe longer away from this license. And then it's going to take people another 1 year or 1.5 years to get those licenses and to actually be able to start to provide services. So I agree with the idea of, you know, we moved pretty quickly during the COVID pandemic. Why is it taking so long? And I'm gonna say, I think it goes back to that issue of stigma and discrimination and this fragmented healthcare system that we have. So the good news is that we are moving towards this license. The bad news is that, you know, it's taking a long time. So, you know, we can talk about different types of models of integration. We can talk about, you know, what's working out there and what's not working. But I'm going to stop there and kind of open things up if there's any questions or anybody else wants to comment.
Based on what both of you guys are saying so far, you know, it seems like as much work as we have all done on all levels, on stigma, on discrimination, you know, we all know that we still have a very long way to go. that brings me to some of the things that we want to address from the frontline perspective. So this is coming both from our patients, our folks that we work with, our frontline outreach workers on all levels, whether they're in. Now, I'm going to phrase it this way based on what Mike was just talking about. So currently, part of the fragmented system that we have is the way we are doing the licensure and the funding and everything currently is we currently have what we term recovery services sitting under one division, which is human services, and under that it's Division of Mental Health and Addiction Services. So technically they oversee what we term recovery services and recovery support services. The Department of Health oversees funding and licensure for what we term harm reduction. Now, so when I separate the two, I am referring strictly to those funding divisions and those oversight divisions. I want to make it very clear that myself, the people on this call, and our philosophy going forward, I am not separating those two things. People that know me know that I spend a lot of time talking about how recovery is harm reduction and harm reduction is recovery. There is no distinction between the two things. Okay, so I just want to get that out there because it's very important to frame the rest of the conversation under that. But as far as when I tell people what I do now, I tell them I sit in that intersection because I am often in a position where I am explaining harm reduction to people that don't understand harm reduction, and I am explaining recovery, traditional recovery, I should say, to people that do not understand that traditional, again, air quotes, traditional recovery, to people that come from a medical background or come from a different perspective. Because what we are seeing is that now we are hitting stigma and discrimination on both of those sides. So I think that this happens a lot. We end up polarized on lots of different fronts for lots of different reasons, when it seems like the answer is always somewhere in the middle, because there's never one simple answer. It's always very complicated. But we all know that while we're working all of these details out, while we're, coming up with the guidelines and talking about things and doing the education, it's our folks that we work with that are dealing with the fallout, with the confusion, with the fragmentation. So we have people coming in, whether it's coming into seeking addiction service treatment or whether they're seeking physical health treatment for wounds related to their drug use. And we know that these wounds are different, okay? Wounds are not new to people who use drugs, but before it seemed like, and please correct me if I'm wrong, Doc, but it seemed like before, when we talked about drug use wounds, we were always talking about people who used intravenously. There was always a needle involved, and it seems like xylazine wounds are not in that category. They are something different. So anybody who is using any kind of drug that xylazine might be in, and they don't know what it could be, all of them, it seems like it's most of them. So they're all at risk for developing these wounds, and they're really different. They're like on a different level from what we have seen in the past. So they have a very emergent and dangerous health condition that they are having a lot of trouble getting help for. Because, and this obviously depends on where they're going. We are getting reports of like some hospitals are dealing with this in a fantastic fashion. Like they do it all the time. They have certain doctors that are coming up with better protocols, because there doesn't seem to be one standard protocol, because they're trying to figure it out. We're kind of like building the plane as we're flying it. But unfortunately, the vast majority of the reports that we are getting is still lots of stigma and lots of discrimination. So we're getting stigma from medical staff. People don't, they're not showing compassion. They're not showing any kind of empathy. They're immediately putting people into you use drugs, therefore we're not going to adequately treat you. They look down on them. there's a lot of the disconnect of, we are missing the window that the doc was talking about, because people have to get these wounds treated before they can go into other services. And there's really not a lot of encouragement from medical staff of where they're receiving treatment for these wounds to go back into any kind of services afterwards. And also, it starts with the wounds, but that's an open door to having a huge discussion about what is going on in that person's life. And we know that, ER medical staff is on a pretty strict time frame. Like they don't have time to sit and have lengthy discussions. But we do have people in the ERs, in most ERs now, that are there for those purposes. We do, in a lot of our hospitals, we do have peers. The ones that we don't still should have social workers on call. There's always somebody that should be talking to our folks, and we're finding that it's still not happening. No one is taking those wounds as an opportunity to meet with that person and say, here are some other services. We know that people are not being introduced to our harm reduction centers. I know we have a lot of participants on today who work in our harm reduction centers. People are still not talking about accessing harm reduction centers. They're still only talking about, you use drugs, you should stop using drugs. This is where you go to stop using drugs. They're not encouraging them in any kind of actual harm reduction framework. There's still a lot of places that aren't talking about medications that are available to people as an alternative or as in addition to safer use. One of the things that we have heard way too often, and this is one of the scariest things as advocates that Tanya and I have been dealing with over the past few years, is we are actually getting reports from a lot of different places that people are coming into hospitals for drug-related issues, usually wounds or even overdoses, and their belongings are being searched. They're finding drugs in their belongings. Then they're calling the police, and then the people are being arrested. So a person is seeking medical care and ends up being arrested, which flies in the face of everything we have been fighting for and advocating for in all of these years that most of us have been doing this. So what are your recommendations for how we address, and this is for both of you, how do we address the stigma and the discrimination for people that are on different levels from where we are? So for instance, like I am known as an advocate and a peer, and I work frontline services. I do a lot of education for people that are in recovery. And now in my new position, I do a lot of education for professionals within the realm. But I also know that like doctors like to talk to doctors and clinicians like to talk to clinicians. So if you're not in that pool, like how can we educate people? Because that's kind of what it comes down to, right? The stigma and the discrimination ends up being a lack of education. How can we do in reach? Shout out to Kim Govak for that phrase. That's her big phrase. How do we do in reach to people that are not part of our own personal traditional circles? What is your advice for that? And either of you can take that question.
Want me to start, Mike? Want to start? Great question. And you're right, Heather. Doctors want to talk to doctors, nurses want to talk to nurses, because like the peer recovery program, we feel you don't know what it's like to do my job, or you don't know what it's like to be me. So I need to talk to my own people. It's a hard question. And what helped me early on understand that recovery is possible, and maybe not recovery is possible. Well, recovery is possible, yes. From the ER, we often see the worst. We see people in crisis. And if someone is practicing and only seeing that for a decade, it is hard to imagine the other side of that, and that human being achieving the goals they have set forth for themselves, feeling they are living a fulfilled life, whatever that looks like. It's hard to imagine that because we traditionally infrequently see that. we kind of see of all human diseases, we see the worst of it. We never get to see the good stuff. So what helped me early on when I first met Mike, probably 10 years ago, was the
It was
seeing.
longer. It was like
Was
15.
it? Was it? Okay, fair. When the ORF grants came out, that was the first time we saw people in long-term recovery. And it was shocking in the best kind of way. So we don't necessarily need peers to peers, although I in my current role at RWJBarnabas Health, that's why I was hired. We have, as everyone knows, a big peer recovery program, but the doctors weren't really doing anything, weren't doing their part. And we felt maybe we needed to fill that gap, and we've been pretty successful. But seeing folks in long-term recovery goes a long way. So when I think step one, I'm not sure that the hospitals, well, I'm going to try to be political. I'm not sure that the hospitals are going to seek out relationships with harm reduction centers or treatment facilities on their own accord. They should, but they may not. So in the event that they are not that it sucks to put the onus on everyone else, but the folks in that space, the harm reduction folks, the treatment providers, I said this at the New Jersey Prevention Network conference, I think they need to bang really loudly on the doors of the hospitals. So really, really loudly, find out who the community relations folks are, who your champions are. Just how do you get in? How can you just get in through the crack and be loud? Explain to them who you are, bring people in long-term recovery, bring the stats of how harm reduction reduces morbidity, reduces mortality, and is health engagement. Mike, I love that. I heard you say that a while ago, and I've adopted that. It is about health engagement. We don't see that because we traditionally were not taught that that's a thing. So in the acute care setting, we have blinders and we are siloed. And unfortunately, the blinders aren't coming down very quickly. So I think that they need to come to us. And again, it sucks that the onus is on the other team, but come in and really show the benefit of collaboration. I think that is step one. And seeing people in long-term recovery, hearing the success stories of harm reduction, and whatever that means. If we were injecting and now we're snorting, that's great. That's part of recovery. Someone was completely undomiciled. Now, they're popping into a shelter. They're getting a warm meal. Great. But we need to see it. We need to hear it, and with passion. And of course, everyone on this call has passion. So I would recommend that. And I'm here to help in any way I can, but banging on the doors of the hospital and demanding time. It is a public health crisis. You have no excuse. You rallied for COVID. We're asking that you rally for us. It would be grossly inappropriate to say no.
Yeah, and thank you for going first, because that was a tough question. And you did a great job answering it. I agree with everything you said. I think, we certainly have to take a top-down and bottom-up approach, right? And so really we've got to make sure we get our stories out there to everyone, right? And not just our personal recovery stories, which are incredibly powerful, but also the real data, right? Not these myths that have been, floating around for years and years and years. We did a lot of damage. When I say we, those of us in the treatment community early on, because we adopted that acute care model. And really, probably the first 10 or more years of my career was spent in really an acute care model. We did very brief treatment that was focused on stabilization, right? Detox, short-term residential. We developed some of these myths about how people didn't recover, right? I remember being in programs where we were telling our clients that 1 out of 15 of you are going to make it, right? I mean, just think about that and the impact that has, first of all, on the people we're serving, because our job should be to instill hope, not to take it away from people. But how, that message gets out to people in the community, right? And to decision makers and to politicians and to people in the healthcare system. They don't get better. Why should we even bother? We now know that that is not true. Yes, this is a complex illness. Yes, most people have to go through 4 to 5 treatment episodes over an 8-year period before they get to sustained long-term recovery. Yeah, recovery is difficult, right? And it's not an easy journey for many people. But we also know 70% of people who seek recovery get to a place of long-term sustained recovery. 70%. Now, that's a lot different than the 1 out of every 15 that people used to talk about 20 years ago, right? So there's a lot of data out there that supports that recovery works, people can and do recover, and that that integrated care can really increase those outcomes, that peer recovery support can increase those outcomes. I attended a really great workshop recently with Corey Ville-Saint from the Recovery Research Institute. She was talking about data that they have now, because they had data that said that a person in recovery, it took 15 years for a person in recovery to achieve the same levels of basically quality of life levels as the general population. We now know that active engagement in recovery community centers with that peer recovery support can bring that down to 5 years, right? That's the kind of information that we really need to be getting out there. We know that integrated care saves lives, that leads to better outcomes. We know harm reduction saves lives, right? Engages people in treatment, right? So we know that all of these things work. So we need to get the information out there. We need to get it from the top down. We need to get it to our politicians, our decision makers, and we need to inform the general public. And I'm going to say this, there's still a lot of stigma within our treatment programs, like you said, around things like MAT, MOUD. It's still a lot of stigma around harm reduction, probably even more, right? So we need to educate our treatment providers more so that they can better advocate, and we need to inform. And this, of course, this is the great work that you all do at NCAAR to inform all of those folks, including the people we serve, so that they can advocate for themselves, because they're I'm a person in long-term recovery. We are the best. We are the people who are best suited to advocate for better substance use disorder treatment, recovery support services, and general health care. Oh, one other thing I will throw in there. If we really want to make things change, we need to incentivize providers to do that. So you pointed to the problem of at the state level, we have, over here, the Department of Health does licensing, and the Department of Health kind of supervises harm reduction. And then over here, the Department of Human Services, they run the Medicaid programs, and they, do all the Division of Addiction Recovery Support programming. They all have to get on the same page. They all have to work together. And they really need to look to incentivize. If we're going to if we're really going to make integrated care work, we have to find ways to financially incentivize providers to practice integrated care, because that is one of the barriers. One of the barriers is just not enough funding to support it right now. I tried at 2 different programs, and the funding, forget about the licensing barriers. If you can even get through the licensing barriers, then try to fund those programs. It's extremely difficult. So we need those kinds of incentives. They're doing it with the CCBHCs, the community, the certified community behavioral health clinics. They're getting some incentivized payments. They're doing with federally qualified healthcare centers. Those are 2 very good models of integrated care. They need to do more of that kind of incentive, value-based payments, and those kinds of things to incentivize providers to provide these services.
That brings up a really great thing that we have to ponder, because what are those incentives? Because, as we're talking about the integrated licensure and the concern about how long it's going to take, I mean, even if it was all done and it came out tomorrow and people could get it, within 6 months. It would be an absolute disaster if it was rolled out right now, because like if we look at, to draw a somewhat related but not really parallel, like the decriminalization effort in Oregon, those of us that have been watching it know that it looks like it didn't work, but we know that number one, they didn't give it enough time, but number two, they didn't give it enough infrastructure before they changed the law. Now at NCAAR, we do this all the time. Like when we are looking at legislation to get out there to everybody and say, these are the bills, this is the legislation. There can be some good legislation out there, but if there isn't adequate infrastructure to support those laws, then we have created a lot more problems. And if we changed everything licensure-wise right now and told all of our treatment providers, this is now how you will approach it, we are going to have an issue, because we have a problem with treatment in New Jersey. And we have it with it all over the place, but I'm only going to talk about New Jersey because I live here and I work within our treatment realm here. We are not implementing the models that we know that we are talking about here. We know work, we know we're successful, we know have better outcomes. We are not implementing them at all, or very like teeny bit in our treatment centers. And we need to change that philosophically before we can roll it out programmatically. So I'm also a person in recovery. Everybody knows that. Everybody knows I am. Everybody knows Mike is, because we wear it on our sleeves. We created a culture where people in recovery can be that way. Thank God. But I'm going to own this as a person in recovery, and I'm going to say we need to, those of us that have been around for a hot minute, we need to stand up and do what Mike just did. We need to say what we used to do, the acute care model. It worked for then, but we made a mistake. It doesn't work now. The things that we have learned in the past 10 years about neuroscience, about how things work, about the brain chemicals and synapses, and like, we just know so much more. I can't even imagine where we're going to be 10 years from now. But we need to get our people that were trained years ago or learned the old school way of thinking. We need to get them to do the same thing. We need to have them in the same boat that Dr. LaPietra was talking about, where doctors they take this vow about being lifelong learners. We all need to be there too. We all need to encourage our community to be lifelong learners and start making a bigger distinction between what worked for me and what works for every other individual. I think that's really roadblocking a lot of this. We need to get our treatment community on board. So we need to get medical folks on board. We need to get clinical folks on board. We need to get the community on board. And we have people here that sit at those levels. What are the kind of things that work for your section of the community? What speaks to them? Like, what works? If you want medical folks to change their mind on things,
forever.
like, what are some of the ways that we reach them? What are the ways that speak to them? How about clinicians, Mike? Like, what are the best ways to approach that? Obviously, I can't walk up to them and be like, you're wrong and you need to do it this way. It's not the best approach. Though when I started my career, people know that I was really big on that. I have learned, but obviously different communities are going to respond in different ways. So what do you think are some of the ways we can do that? What incentivizes medical folks and clinicians to learn different or newer ways of doing things and adopting them into their practices? What do those incentives look like?
Well, I'll let me talk about that on a personal level. I mean, my whole interest in integrated care came from working with patients, clients, and realizing that we weren't doing a good job, right? just plain and simple. We weren't doing a good job. And how could we improve outcomes? And so starting to look at alternatives. Unfortunately, not everyone has that mindset of, some people just don't have that mindset of let's try to fix things, let's try to improve things. But I think that we need to train our staff more effectively on what works and what doesn't work. Listen, even today, people come into an agency and they're given a caseload and they receive a limited amount of training, they receive a limited amount of supervision. We need to do a much better job of training people, not only what we do, but also what else is out there. What are the other services and how do those other services? I'm shocked today that I still meet treatment providers that don't really even know anything about recovery support services. Like nothing about recovery support services. So, and their understanding of harm reduction is very archaic and incorrect. So we need to do a much better job of training staff, both in academia and in the actual work environment. So the other issue is that I think, boy, I might get myself into trouble here, but what the heck? I'm almost fully retired, so who cares? We've been talking about the Medicaid carve-in for since the Affordable Care Act, right? And thank God for the Affordable Care Act, because that opened up a lot. We probably would not even be having these conversations about integrated care if it wasn't for the Affordable Care Act. And it's helped to grow capacity and it's helped in terms of access. But we developed this thing in New Jersey called the interim managing entity, right? The IME, interim. It's been interim for how long now? How many years? So we've known about this Medicaid carve-in for 8, 10, whatever, how many years it's been. And we're about to move into it, right? Like the end of this year, we're starting phase 1. And I'm really disappointed that none of this has been addressed. None of these issues around integrated care, how do we provide better quality of care? How do we, integrate these services? That none of this has really been addressed. And it's not going to happen, as I said earlier, unless you incentivize, unless you come up with systems of payment that will incentivize these types of services. For example, like prospective payments, value-based payments. We know if we provide integrated care, there's a payoff. By the way, there's a payoff for the managed care organizations because they're going to save money in the long run. So I'm really discouraged. I am somewhat hopeful that maybe the managed care companies will figure this out. I'm also, very pessimistic that we might just wind up with a big issue around lack of access. But I'm hopeful that maybe at some level, they may figure out that if we move toward a more integrated system, that ultimately, their profit margins are going to be better. Because let's face it, that's a lot of what drives us, our healthcare system. So the goal, one of the stated goals of this, carve-in is integrate behavioral and physical health for whole person care with potential to improve healthcare outcomes. That's one of the 3 goals for this carve-in. We've really got to hold them to task for that. It's a stated goal. It's on their website. It's in all their documentation. How are they going to do that? Well, the thing that I've heard so far is that there's going to be care managers. It's got to go a lot further than just having care managers, right? So we need to really think about this. This, I think, potentially could have been a time in which we really re-envisioned our healthcare system and made some really significant changes. Unfortunately, that hasn't happened, and I do have concerns, but I also have hope that maybe we'll be able to make something happen as a result of these changes. So.
Thanks, Mike. I think that for the medical organizations, it's about that science you were talking about, Heather. That's my entire platform when I start talking to the physicians, nurses, and providers. because we get so much, obviously, all of us get so much academic foundational education. And by the time we start practicing, some of that is no longer true. But the joke, if it's a joke, is we don't know which part is no longer true. And so we were taught nothing about substance use disorder when I went to school. It's getting better now, but again, the science is moving so quickly. We live in a time where, as you said, the science is moving so quickly that really someone needs to own that. And we have continuing medical CMEs and CEUs. So the state had prioritized end of life and pain management for renewing licensing for physicians and providers. They had to take mandatory courses. Things like that need to continue, because everybody in all sectors of healthcare will see substance use disorder folks, and it is applicable, and there can be such life-saving interventions when you just have a little bit of knowledge. So having things that are kind of, mandatory are important. As boots on the ground folks, we may not appreciate the gravity of these changes, but as a state or as a nation, that leadership must recognize it. So end of life, that's a priority. Primary care docs just add it every day. They may not realize there's science, there's evidence, there's really important movement. So the state mandates that they learn it. That's important. So no one wants to have mandatory courses, but again, as lifelong learners and in a healthcare field where we have very impactful decisions to make about people's lives, we need to know this. So the neurobiology is extremely enlightening for physicians and providers as scientists to hear about the rewiring and the neurotransmitters involved. And what's nice is we know folks with traumatic brain injury or people who have, brain issues, they recover. It's not a life sentence where, there's no hope for you. So this is again where the peer-to-peer model is helpful. So as a physician, I say, listen, our traumatic brain injury patients, we know if they went to a 5-day detox or a 5-day acute rehab, not much would get accomplished. Few things, but they have a year or they have 2 years or they have a lifetime in which they're going to work on this and make improvements, but it's not quick. And we know everybody wants quick. Physicians want quick, patients want quick. So when I, talk to families, they've been, my daughter's been through detox 5 times. Well, I don't understand. We need to help educate on the brain disease. And Mike, to your point about the folks in the treatment field, when I've spoken to colleagues, folks who are in the outpatient treatment area, I've brought up things like the HIV/AIDS epidemic. So catastrophic. And it's stigma, right? So, I'm thinking, I'm trying to think back, what did we do that worked and how can we replicate that? So postpartum mood and anxiety disorder, or postpartum depression, 25 years later, we're doing much, much better. Well, how did we get there? So we're using some of that for maternal health. So HIV/AIDS, how did we get here? Some of the folks said the issue is everyone really involved in that epidemic was rowing in the same direction. Humans are dying. We need to do the science. This is where we put our dollars. We must find treatment and cures. What I'm hearing is that MOUD, harm reduction are very polarizing. So we're actually rowing in opposite directions. And what does that mean? We stay here. We go here, but we're back. So we're never really advancing ourselves because of the stigma. So the science is super important. People who get on MOUD, 60% reduction in the chance that they'll die. I know that maybe for a long time it was considered a crutch, but guys, fentanyl is horrific and humans are just dropping dead. Guess what? It's time to look at it a different way. So I'm not being in recovery. I don't ever want to disrespect someone's road to recovery. And in talking with a lot of peers and folks who've gone through different journeys, it really sounds like when people go through their recovery, it obviously, it's a huge part of them and it worked for them. And it sounds like they really want to share that with the world, this gift that was given to them. But I'm learning, I did not know, some of the organizations are quite dogmatic, or there's really a line in the sand when it comes to certain things like MOUD or harm reduction. And that's gutting, because we're taking something many, many decades old as a principle. We have so much science, and you're not allowed to kind of bring that science into some of this philosophy. So we, I can only speak for my organization, but at Barnabas, we do a lot of work with folks in long-term recovery to talk about every road to recovery is the right road. Abstinence-based, 12-step, harm reduction, because a lot of folks have been in recovery a long time before really MOUD maybe was offered, or before harm reduction was widely accepted. And it's been really nice to see the evolution in thought, which gives us hope that, like HIV/AIDS, we can all get in that same boat and row, instead of continuing to have conflict on this that is really based in science. We can't argue with science anymore. We've got to make it standard of care.
Thank you, Doc. That is something that I would like to see just kind of across the board. And I think that coming from, I'm going to speak from like clinical and peer perspective. So what I really like about what you just said is that, because in the peer and the clinical realm, we have finally gotten people to a point where they are accepting this multiple pathways to recovery idea. So people know that if they are not accepting the philosophy of multiple pathways, that they are behind the curve, okay? But now we're realizing that that was not the right phraseology, because people might accept multiple pathways, but they're still putting them in a hierarchy and acting as though certain pathways are preferable or certain pathways are better. And that is incredibly detrimental to the folks that we are serving. The only right pathway is the one that works for that person. Like, that's the right pathway. It might not be the right pathway for me. The right pathway for me is the one that works for me. Mike's right pathway is Mike's right pathway. Like, that is the thing. And I know there's many of us out here that this is our kind of our crusade right now, is making sure that people are delivering services in the right framework. Like, harm reduction is not a step towards something unless that person wants it to be a step towards something. Like, harm reduction is something in and of itself. It is a medical model of care, you know? But I think that this is something that we are really, really missing the boat on, with even modern day training of our clinicians and our peers, Mike. Like, we don't do neuroscience. And I will tell you, just on a personal note, that was one of the most life-changing moments of my own personal journey. Sitting in my own treatment many years ago, when they did that neuroscience piece and they put those slides up and they were like, this is what a normal brain looks like. And this is an MRI of a brain on this drug, on this substance. This is what the brain looks like 6 months, 9 months, 2 years later. It was the first time that I ever saw it and went, oh my God, this is what it means when they say it's in your head. Not that I'm making it up. Like, it's literally in your head. But a lot of our providers are still doing it in the vernacular, as in, it's in your head and therefore you can change it. You think yourself well, and that's not how this works. And so, Mike, how do you think, what is your opinion? This is an opinion piece. If none of us want to be mandated into required courses. Like, we don't want that
Right.
any more than the docs do. But obviously, we all do have to take continuing education on any certification or licensure level. So I would advocate, if they were going to mandate anything, it would be something in this science realm, because I don't think that we get enough of that. What do you think the reception to that would be? Do you think we're at a point yet where people would do that?
Well, I mean, in every treatment program I've ever run, I mean, there was a big focus on that. And
Yeah.
like what you said, I've had many, many clients say that those were some of the most meaningful education sessions that they got, because it helped them to understand their illness, right? I mean, that really is the root of their illness. So they find that very helpful. I remember one woman saying, you know, wow, I realized that I'm sick, I'm not crazy, and I can get better, right? So, so I think that, you know, treatment administrators, leaders need to take responsibility for their agencies. I mean, first of all, they need to become educated, right? And listen, there's a lot of old guys like me running programs, you know, that have been doing this for a long time, and they're kind of comfortable, and, you know, they're comfortable doing what they do. And, you know, let's not rock the boat, and let's just kind of keep doing what we're doing. I mean, let's face it, that's the fact. But again, this is where, you know, the state and funding sources can put pressure on those agencies. Um, uh, and we may, you know, I don't know that we necessarily want to penalize them, but let's incentivize those that are doing the right thing. But I think we, you know, as leaders within our communities, whatever that is, and if you're a leader in a treatment program, you have to take leadership in that. You have to be the change agent. You have to be the one to, you know, ensure that your staff is receiving that treatment, that training. Both treatment programs that I ran, that was a big part of what we did. We did a lot of training around, you know, things like recovery-oriented systems of care, the chronic management model opposed to the acute care model, and those kinds of things, so that people really got a better understanding of the illness, really got a better understanding of how this illness works, how people recover. You know, recovery, you know, the majority of people don't recover, as I said, by just going to a detox. But I can tell you that there's a lot of people who work in detox programs that think that equals recovery, or that think a 28-day program equals recovery. And for some people, it might. But for most people, they need a tremendous amount of support post those acute care services. So, you know, that education that goes beyond whatever service you are providing in your agency is really important. And those people who are running the organizations have to take on that responsibility. And certainly, you know, even if the administrators are not the clinical supervisors, really have an ethical responsibility to do that. And it is really an ethical responsibility.
Yes. Sorry. It's an ethical responsibility because it's unethical
Not to. Right.
be practicing something that may promote morbidity or mortality, even if, you know, you were not aware. Agreed.
Yeah, actually, so obviously, those people on, not just on the screen, but those watching know that when I do webinars, I'm on my better behavior. Don't worry, Summer, don't have a heart attack. I'm staying on my better behavior, but I'm going to use a phrase that people have heard me say a number of times, and it's when people in all realms, it's not just one particular area of our field, but in any part of our field. If we are taught better, so we have the data and the statistics about medications, about harm reduction services, about all of the things that we are talking about today, and still insist on pushing people into particular pathways or particular philosophies. That's where I draw a parallel with the medical field, because if a doctor was doing that, we would have a way of addressing that. So I would like to believe that you know, this 1 in 15 number that Mike was talking about, that we used to hear, they are still using that, except usually it's like the, you know, look around the room, you know, only 3 of you are going to make it. Like, if I went to an oncologist because I was diagnosed, I had some kind of cancer, and my oncologist said only 3 out of 10 of my patients live, I'm going to find a new oncologist. Like, those are very bad statistics. And if I'm not given any other option, and the doctor insists on treating my cancer the same way they treated cancer in the, you know, 20s, 30s, or 40s, even though they know that there are other options that work better, and you know, have a higher success rate, I have an option. I can sue that doctor. I can sue that doctor for malpractice.
You can go to the state. You
Yeah.
can go to the state medical board.
This is a public health crisis. I think like we're all in that boat. And I'm not advocating for being able to sue everybody. We're in a like overly litigious society as it is, but I'm using it to show how we are still, like, we say this is a public health crisis, but our framework is still not set up to treat it as an actual health crisis. So how do we encourage, like, people that are on this webinar today? A lot of them are in the thick of it, doing the services, saying, why aren't we getting state support? Why aren't we getting licensure support? Why aren't we getting training support? They already know. A lot of the people that are showing up today, they already know about what we're talking about. So how do we get to the people? Like, we're the bottom up. I'm talking about the bottom up people. Like, we're doing the work. How do we get to the top down approach so we can do that meeting in the middle thing? Because Mike, you're right. It's got to be top down and bottom up. How do we do that?
So, let me use the example of MOUD for, let's use that. And we just talked about unethical practices, right? And I think everybody on this panel will agree that if you are a substance use disorder treatment program and you are not offering MOUD to someone with an opiate use disorder, that is unethical practice. And not just offering it, but really educating them on the benefits of MOUD. That is unethical practice. And in the traditional medical healthcare world, you probably could be sued for that. It doesn't happen in substance use. We're not I'm not part of we already talked about the part of the problem is the regulations, right? But I'm okay with smart regulations, right? I'm okay with regulations that improve quality of care, right? I have no problem with you want to give me 1,000 new regulations that improve quality of care, I'm okay with those. The ones I'm not happy with are the ones that prevent us from improving quality of care. But we need to really regulate that. I mean, that needs to be regulated by our licensing, state licensing, the Department of Health. When they go in to do their site visits, they need to really look, are these treatment programs, is that part of the services that they're providing in the programs? Are they providing adequate education around MOUD? Funders need to monitor programs and say, wait a minute, you served 2,000 folks last year with OUD, and only 5% of them winded up on medication. That's not best practice. So there needs to be some regulation about what is best practice. And I've got no problems with creating regulations for that. Let's get rid of those regulations that prevent or disallow us from doing best practice like integrated care. But yeah, we've got to enforce that, and we've got to educate the consumer so that they can then use their voice to file complaints, because there is a complaint mechanism for SUD treatment consumers. So they need to file those complaints and say, hey, I was in a treatment program, I have an opiate use disorder, I was never even offered MOUD.
May I comment, Mike? I agree. I think a lot of folks these days are really medically literate, and there's so much information that you can gather online about different healthcare conditions. So when folks go into the hospital with a traditional medical issue, they sometimes come in with some expectations. They talk to a friend or a family member who's been through it. They looked something up so that they, may expect a certain medication or may expect a certain test. And they do, they're vocal and they ask for it, and we have to be able to answer it and talk to them about their expectations. I feel that we're not there yet with the substance use disorder community and their families. So if someone came into the hospital with diabetes, blood sugar was really high, we helped with insulin, you would expect them to go home with insulin for maintenance, even if they were going to completely change their lifestyle. And it would take time, and we need to reduce the harm while they go through that process. So I talked to a group of folks who are interested in getting more involved with harm reduction, and I explained no one's saying, where's the Suboxone, or is there any options for methadone, or I'm not going to stop injecting, but is there somewhere I can go to do it in a safer manner? And so I do think that the community in of itself and the family members and the people supporting folks with use disorder also need to speak up and not just advocate for 5-day detox or the quick fix, but know the different options and demand it. And that will get the attention of those higher ups when there's patient complaints. That's a big deal. We want to provide, I mean, all the hospitals have mission statements and patient relations departments and patient experience. And we want to really be able to treat our human beings. And this is a piece where I think, families making some noise, that those squeaky wheels get the grease. So I do think it's important just to empower so people have options. Right now, I feel as though they don't feel they have any options, and they don't have any other information to suggest otherwise.
Thank you both. So Mike, you just mentioned best practices, and Doc, you're talking about like what people can do once they're in the hospital system. And I know like we were talking more about the wound care in the beginning of this, so I want to circle back around to that, but specifically regarding best practices and what the hospitals are doing, because it's important to talk about why people are not getting adequate wound care in a hospital. Like that is part of the problem, because drug use or no drug use, if people are going in for any other kind of wound care, like they have that expectation that you were just talking about. So stigma aside, okay, because we know that that's really the part of the answer. Like people are not getting adequate treatment for their wounds because of the stigma and the discrimination. But Dr. LaPietra, could you talk a little bit about what they're talking about with wound care in the medical end of things? Because I know there are some issues surrounding that term best practices right now.
A few things. Folks coming into the hospital who do need wound care, we have to, as Mike said, treat the whole person. So one issue nationally, and certainly in the state of New Jersey, is we do not manage opioid withdrawal or xylazine withdrawal. So although we're pretty good at wounds in the hospital. I mean, there's a lot to learn about xylazine, and there's a lot of hospitals have wound care teams, which is great. So we have to do more education on xylazine wound care in general. But if you're in the hospital and your other medical conditions are not being managed, you are going to leave. So that is what I have been discussing and what senior leadership agrees with in terms of the whole person approach. So again, if someone came in for a pneumonia, but you said, I'm sorry, I'm not really sure what to do with your diabetes, so you're just going to have really high blood sugar. If you're not treating me, I'm going somewhere else because this is a medical problem. It has medicine and I'm in a medical setting. So starting with management of withdrawal symptoms is of utmost importance. It's a huge priority for me. It, like any big cultural change, it takes a lot of time, but certain healthcare settings healthcare systems are prioritizing that. And that is the beginning. So wound care in the hospital, education needs to be done on how to care for those wounds, but those folks are going to leave. That's the bottom line. They're going to leave if you can't address all medical issues. So that's one failure to that population, is we are not allowing them to stay comfortably if we're not managing withdrawal. The other issue is the traditional wound care follow-up and that stigma and discrimination about understanding that people who are still choosing to use deserve and should get the exact same care as someone who is on MOUD or maybe practicing abstinence or whatever. That's a big cultural shift, again, for it seems like everyone, but it's unethical And it is wrong to draw that line in the sand. Well, if you're still injecting or you're still snorting, I don't understand why I'm addressing your wounds every day. Because I'm a human being, I have a medical issue, and that health engagement, we know that folks who engage in harm reduction, they, continue on a road to recovery, potentially more so than when they're just shut in the corner, no one's addressing their issue. So that's an uphill battle, and there's a lot of work, but that does need to start, is for the medical professional, and that low barrier access to wound care is what the evidence shows works best. For xylazine-associated wounds, it's daily wound care, which requires somewhere for them to go daily. So an OTP would be a beautiful setup for that if we can get there, that daily health engagement, that daily wound care in a low barrier setting. But again, if you don't want to start on methadone and you're simply asking for your wounds to be cared for, but you are using, that doesn't disqualify you from health care. So that's an uphill battle, but it's being talked about. And of course, we need better infrastructure everywhere for that.
Thank you, because we know that, like, obviously we're seeing these wounds everywhere, but it's in certain pockets that it's much more pronounced. It's very geographic, though it is spreading statewide now. But in areas where it has been especially prevalent for a longer period of time, we know that people are no longer going to the hospital because of the treatment that they received. And so a lot of people are now becoming, like, a lot of outreach workers are becoming as proficient as possible in wound care as they can. So they are doing as much as they can, and it's wonderful because it's at least keeping things clean and packed. And I mean, like, people with very little medical background are much more proficient in treating these wounds than a lot of other people are. But we all also know that without antibiotics, without the actual medical piece, in addition to that, these folks are open to a lot of complications that are lifelong. We're seeing a lot of amputations or needed amputations, and adding that on top of everything that our folks are dealing with is just heartbreaking. And so I know a lot of us are trying to be as proficient as possible in doing wound care, but we are really we'd like to encourage our folks to get the actual medical care, but we only want to send them somewhere where it's safe. So,
yes.
Heather, and so I also think it's really important to encourage mobile outreach efforts, whether that's like a mobile harm reduction or mobile physical care, because there are a lot of folks out there who have lost trust in the healthcare system, and I'm including the substance use disorder treatment in that healthcare system, and they're just not coming to the brick and mortar sites, and we really have to go. We have to go to them. So I think that's that next area where we really need to focus on is doing that kind of mobile outreach. And there's a lot that can be done through a mobile outreach vehicle that's well designed and well equipped. You could do primary care, you could do wound care, you could do preventive. We didn't even talk about preventive care, but there's a whole group of services that could be provided through that mobile outreach, because there's a large group of people that we're not even connecting with.
Right. And I want to, so, like, obviously we want to continue to work on all of the things that we have been talking about today, but we all know that that's a very lengthy process, and we'll continue working on it. But what do we, to have kind of like final thoughts in the meantime, since we know that we're just going to see more and more of these wounds as the xylazine creeps into more geographic areas, and it seems like the amount of xylazine is climbing as well. The percentage markers are climbing in each thing that is tested. What do you think? What can you tell people that are on the webinar today that would help them assist folks in the short term? Folks that are resistant to medical care because of what we've been talking about, folks that are resistant to having their wounds looked at, or engaging with community treatment providers because of this. What advice can you give to them, or what resources do you recommend that they can do to help our folks that are out there that still need help while we're working all of our magic in state and division levels? What do you want to send folks home with today?
Well, one of the things I would do is access the recovery support programs that are in your community, because that peer-to-peer relationship can be very helpful. Every county now has a peer recovery supports a peer community center, recovery community center, and a peer can be very helpful in helping folks navigate that system and kind of directing them and supporting them through that process. We know it's very challenging navigating the healthcare system, whether it's substance use treatment or any other kind of treatment. And I think that peer-to-peer relationship can be very helpful in helping people navigate that system.
I would ask the boots on the ground teams to be really transparent with each other about who's doing it right. And I understand that geographically as a state, there are pockets of teams that are doing a really good job. And then there's, of course, areas where there's a deficit. But if we can communicate across the whole state, get together and have those boots on the ground teams identify organizations that are treating humans like humans, that have operationalized harm reduction in the way it should be, partnering, we all need to be open books, and we all need to appreciate there's a lot we need to learn, and we're all in it together. So, not competing, there's plenty out there, but just trying to be more collegial and more transparent. And if an organization is doing it great and there's an organization next to you that's not, I think we need to meet with that organization and discuss the evidence, discuss the operations to the best of our ability, and to try to see how we can translate what works in Passaic County, over to Essex and so forth and so on, because it is getting done. As Mike said, even mobile units, it's getting done, but we have to try and scale what works and not continue to reinvent the wheels, sometimes in our own little silo, but really all just say, that's it. This is friggin' hard. Let's just talk about it, and let's try. Let me see what you're doing. Let's see if it's going to work. I'm going to try to keep an open mind, even though I may think you're a little nuts. I don't know. They're doing it. So let's all be a little nuts. Let's just try to be more flexible and communicate more on our wins, because we know there's plenty of failures, and we need to celebrate the wins, and we need to scale the wins.
Well, I'd like to say thank you so much to both of you. I had a lot of fun. I hope you guys did too. This was a really great conversation. I mean, we covered a whole lot of stuff in a very short amount of time. And I think I know I'm leaving with a little bit of hope that even when it seems like we're all coming from very different areas, we are actually saying the same things, which, even if we're saying the same, not so great things, it's hopeful to me to be on that same page, because that does mean that we have even more people in our camp. And so, at NCAAR, we're notorious for having a call to action at the end. And so, Mike and Dr. LaPietra just gave you their calls to action, and I'll give you one of mine, and that's to work within your own community in the same way that we were just talking about, and to encourage other people to come aboard, because I think because we are very passionate people, we tend to really go kind of overboard in our passion sometimes, and we push people away inadvertently, when in reality, we all do kind of have the same bottom line. We want to stop losing people. We want our folks to stop hurting. We want our folks to have a better quality of life on their own terms, whatever that means for them. And so I'm asking you to consider bringing in some of these non-traditional folks, and realize we're all working together for the same thing, and we have a lot to learn from each other. So thank you all for joining us today. I hope you guys got as much out of it as I did. If there are any questions, thoughts, follow up, please email us. Summer, do you have final thoughts? You want to take us out?
No, thank you everyone for attending today. Thank you, Mike and Dr. LaPietra, for your wonderful insights. And the conversation went so many places, way past wound care and much more into integrated care. And it's a wonderful call to action for all of us. So thank you, everyone, and we will see you soon.